Welcome. In this lecture, we'll be discussing acute stroke. The goal of this video is to understand the general workup management of an individual who presents to the emergency department with signs and symptoms of a potential acute stroke. We will also differentiate the different subtypes of stroke and how these present, as well as the risk factors associated with each one. We will not discuss the different symptoms as well as different presentations that we may see comparing cerebral to cerebellar to brainstem strokes. That will be covered in other lectures. The reason why stroke is so important is because it is the third leading cause of death in America. Now, there are two primary categories: ischemic, due to lack of blood flow, which makes up roughly 80% of all strokes, and hemorrhagic, due to rupture of an artery, which occurs up to 20% of the time. Now, ischemic can further be broken down into thrombotic, which is a plaque or atherosclerosis at the level of the artery, or embolic, which is due to some sort of vessel thrombus or vegetation that may knock off and lead to obstruction from another site. Hemorrhagic can also be broken up into subarachnoid, which is covered in another lecture and will not be discussed in detail here, as well as intracerebral. Now, both subarachnoid and intracerebral make up 10% each. So ischemic makes up 80%, subarachnoid 10%, and intracerebral. We will mainly be discussing the three highlighted in red. Now let's talk about how these may present. Hemorrhagic typically presents as a focal neurologic deficit early on, and then the symptoms actually get worse over minutes to hours. The reason being is because in hemorrhagic stroke, this is a space-occupying mass or lesion. The high-pressure artery causes blood to accumulate and puts pressure on the brain. As this worsens, as this spreads, the symptoms also spread and also worsen. Thus, the symptoms still get worse over time. You also see potential signs of increased intracranial pressure, such as nausea, vomiting, headache, and papilledema. If you see papilledema mentioned in a question stem, always think increased intracranial pressure. This is actually managed treatment-wise. When we discuss the treatment management of hemorrhagic stroke, we actually look for these signs of increased intracranial pressure. You also may see Cushing's triad, which is a triad of three different vital signs: hypertension, bradycardia, and irregular respirations. Now, simply put, the increased intracranial pressure leads to a constriction of arterioles, and in turn leads to ischemia. This leads to a compensatory peripheral vasoconstriction, which causes hypertension. This allows for blood to be delivered to the brain, as the body is perceiving this as decreased blood perfusion or ischemia. This activates a baroreceptor reflex, which can cause bradycardia. When it mentions irregular respirations, typically on exam questions, this is shown as decreased respirations, so less than 12. Embolic, on the other hand, is typically symptoms are worse from the start and then they get better. Embolic strokes are caused by some sort of thrombus or vegetation that knocks off of somewhere else in the body and then travels and causes an occlusion. This typically gets better because the body's fibrinolytic system helps break down this clot. This is highly associated with irregular rhythms and pulses. Be sure to be on the lookout for this on exam day. Thrombotic cause is due to atherosclerosis or plaque buildup at the site of the lesion. This typically occurs with waxing and waning symptoms. The reason being is because when we have ischemic stroke, and especially a thrombotic stroke, our body responds by increasing blood pressure to help to deliver blood to that area. Our own body's fibrinolytic system also helps break down the clot. This allows for blood to pass through and the symptoms improve. Because the plaque buildup is occurring at the site of the lesion, plaque can further develop, leading to occlusion. A full clot forms, and you have worsening symptoms. So simply put, hemorrhagic stroke typically starts out here, and it'll get worse over time. Embolic stroke starts out as bad as it can get, and then the fibrinolytic system breaks it down, and the symptoms get better. And then thrombotic stroke typically goes up and down and has this waxing and waning course. Now, let's discuss the overall risk factors that are associated with these presentations. Now, without a doubt, a very high yield topic is that prior stroke is the greatest risk factor in patients with a history of stroke. Be on the lookout for someone who presents with high blood pressure, hyperlipidemia, type 2 diabetes, smoking, obesity, etc., and 25 years ago they had a stroke. That prior history of stroke will be this individual's highest risk factor for stroke. Now, let's say they do not have a history of stroke. For thrombotic causes, high blood pressure or hypertension is the greatest risk factor. These individuals are 4 times more likely than normal intensive individuals to get a stroke. This is compared to hyperlipidemia, type 2 diabetes, smoking, etc. High blood pressure is the highest or greatest modifiable risk factor out of all of those to lead to a stroke. For embolic, the greatest risk factor is going to be atrial fibrillation or some sort of irregular heart rate or arrhythmia, such as atrial flutter as well. Now, there are other causes, such as other causes of left ventral thrombus, such as post-MI, or something known as a PFO. A patent foramen ovale, or PFO, is a small flap-like opening between the right and left atria of the heart. This typically fails to close after birth. Now, PFO by itself typically does not cause any symptoms, but an individual with a current DVT or history of DVT can get a stroke. The reason being is because although the DVT is in the venous system, as it travels and it goes to the heart, it can cross over to the arterial system via the PFO, leading to potentially a clot in the brain. Thus, be on the lookout for this on exam day, as this is highly testable. For intracerebral or hemorrhagic stroke, the number one cause is high blood pressure. Hopefully this makes sense. As the blood accumulates or the pressure accumulates, this causes a rupture. The second cause is something known as cerebral amyloid angiopathy, which is where amyloid beta protein deposits in the walls of small to medium-sized blood vessels, making them extremely fragile and prone to bleeding. This is typically seen in the elderly, typically greater than 65 years old. For subarachnoid, which has been discussed in another lecture, this is typically associated with aneurysms. A lot of individuals believe that genetic predisposition, autosomal dominant polycystic kidney disease are the greatest risk factors, but actually aneurysms are more commonly produced by high blood pressure as well as smoking. Now, look at all of these risk factors. These are all modifiable risk factors, things that we can treat. In almost all cases, hypertension is the number one risk factor for each of these. The only outlier where it's not is for embolic causes or embolic strokes, like atrial fibrillation is the cause. Thus, the number one most modifiable risk factor for stroke will be high blood pressure. The greatest non-modifiable risk factor will be age. This is something that we can't treat, something that we can't change. This is why individuals who are older typically get stroke. Now, that's not always the case, as strokes are or can occur in the pediatric population. Sometimes we can see ischemic and or hemorrhagic stroke. Now, the number one cause of ischemic stroke will be something known as focal cerebral arteriopathy, which is a non-progressive unilateral narrowing of a large intracranial artery, such as the middle cerebral artery or the anterior cerebral artery. This often causes ischemic stroke in children post-viral. So if someone comes in and it's a stroke, young child, CTA, imaging shows stroke, they'll make it extremely obvious, and it's post-viral, always think focal cerebral arteriopathy. A very commonly tested one is sickle cell disease, which is very common in the African American population. Look for someone who has a history of unexplained pain episodes in the past. The reason why this is likely to be tested is because the treatment is unique. People with sickle cell disease who have a stroke are treated with plasma exchange in order to get rid of those abnormal hemoglobins. Now, for hemorrhagic stroke, AV or arterial venous malformation is exactly what it sounds like, where the arterial and the venous system actually combine and communicate with one another, forming a malformation, predisposing it to weakness and rupture. This is the most common cause of hemorrhagic strokes in young individuals, and this typically is treated with surgical evaluation. So that covers both adult, modifiable and non-modifiable, and pediatric risk factors. Now, imaging purposes from a stroke perspective typically go stepwise. Please understand that this is in the acute setting when someone comes to the ED. Now, a general rule of thumb for neuroimaging is we always start with a CT head without contrast. Simply put, a non-con head CT should be performed in patients presenting with a stroke to exclude intracerebral hemorrhage. This does not look for ischemic stroke, as this can take up to greater than 48 hours for findings to show up. So all the CT head imaging tells us, is there a hemorrhage or is there no hemorrhage? Is there a bleed or is there no bleed? CT imaging here on the left is normal. It's very good for looking at cortical bone, but it's not very good for looking at the vessels. This hyperdensity, this white outline out here, that's all bone. Now on the right hand side here, this is what a bleed actually looks like. This white hyperdensity here, circled in red, is what you want to see, or what you may see on CT head without contrast. It is very hard to see ischemic episodes, but very easy to see hemorrhagic episodes. Thus, we always start with a CT head. The reason being is because the next test that we may get is a CTA of the head and neck. That is test number 2 that we typically get. This is typically done if there is no bleed. The reason why this is not done if there is bleed is because the insertion of dye in an individual who's bleeding can actually worsen the stroke or worsen the symptoms because we're adding fluid to this. CTA is very good for looking at vessels. Here on the left-hand side, we can actually see normal. You can see all these highlighted in white. Those are all blood vessels, something known as the circle of Willis can be seen here. Where on the right side here, where this yellow arrow is pointing, we can actually see that this large vessel here actually looks like it stops and then starts again on this other side. This is telling us that somewhere along here, there is an occlusion that is taking place, or some sort of large vessel occlusion. Thus, we always start with a CT head, then we get a CTA head and neck. Typically, this is followed by a CT perfusion. For the purposes of bores, that will always be your third best option. CT perfusion looks just like this. You do not need to know what this looks like and how to describe this on test day. Simply put, this looks for areas of the brain that are salvageable, or simply the penumbra. This is very commonly used for mechanical thrombectomy purposes, as it tells us if we were to treat this individual, how likely are they to respond to therapy. Now, this is your typical acute workup with the first test CT head, then CTA, and then your third test should be CT perfusion. Now, it is important to know that the best diagnostic test is an MRI brain. This is typically not done in the acute setting because they take a while to develop their imaging, and the image itself or the process itself can also take a while. Thus, we typically always start with the CT head. But be careful because on the exams, they might ask you what is the best diagnostic test, not what is the next best step. The next best step will always be CT head, then CTA, then CT perfusion, but the best diagnostic step will be an MRI brain. So let's go over the algorithm one more time. If you have a concern for stroke, you always start with a CT head without contrast. This tells us if there's blood, in which case we need to contact neurosurgery to help us evaluate what's going on, or if there's no blood. If there's no blood and I'm still concerned for stroke, then I want to get a CTA to look at those vessels. The vessels will either show a blockage or a small vessel occlusion, also known as an SVO, in which we treat, which we will talk about shortly, or a large vessel occlusion. Typically, large vessel occlusions are occlusions such as like the middle cerebral artery. These are very commonly caused by emboli. We would then get a CT perfusion. The CT perfusion is typically done to assess therapeutic guidance. But for the purposes of your exam, you always start with CT head, then CTA, and then if you have to choose after, you may get a CT perfusion. But your best overall test is still going to be your MRI. So let's talk about how we would treat these individuals based off their symptoms. So for hemorrhagic stroke treatment, remember, the issue is that there's bleeding into this a confined space. We always start with any stroke with ABCs, airway, breathing, and circulation. Now, the BP goals are very important in stroke management. We'll touch upon this in a little bit later, but we can see that the BP goal is typically somewhere less than 140 to 160. The reason being is because your body is going to naturally react to a stroke by always increasing blood pressure. It's a natural reaction. That's why we see hypertension in Cushing's triad. For hemorrhagic stroke, we want to keep the BP as low as possible, or lower than 140 or 160. The reason being is because if we decrease the blood pressure, it decreases the amount of blood that will be feeding and growing into where the hemorrhage is occurring. We can use beta blockers such as labetalol. nicardipine and cleverprex, which are calcium channel blockers. But our BP goal is very important, and we'll talk about this in the upcoming slides. We can also monitor for ICP. Remember, ICP can be symptoms that we're looking for, such as headache, nausea, papilledema, vomiting. How we do this is we can elevate the head of the bed to 30 degrees, not lie them flat, which will increase the intracranial pressure. Patients may also benefit from hypertonic saline or even mannitol. Hypertonic saline actually creates an osmotic gradient across the blood-brain barrier. Things like to move from areas of high to low. Thus, if the concentration of sodium or salt is extremely high in the blood vessels, this will actually draw water out of the cerebral tissue or the brain parenchyma and reduce swelling. This is very commonly used to prevent herniation. The individuals may require something known as an external ventricular device, or an EVD, which is a temporary catheter placed in the ventricles of the brain to drain CSF and to monitor ICP. Now, these three are great to know and definitely something that you should know for your exam. But where the question will most likely go is, what do we do in acute settings? Or what do we do surgically? If the patient worsens or ICP rises, or even if neurosurgical wants to do some sort of intervention, what are the stepwise options? Well, the gold standard is always going to be a craniotomy. This is the gold standard to remove pressure. The whole idea here is the brain, when it swells with increased intracranial pressure, that causes the brain to move and be pushed against the skull. Sometimes even downwards through the brainstem, through the spinal cord, leading to herniations. Thus, in order to prevent this, we can actually remove part of the cranium in order to allow the brain to have a space to grow into or to swell into. Craniotomy is always going to be your gold standard. Burr holes are your second best option. If a craniotomy fails, or if unable to do a craniotomy, then your option will always be burr holes. This is exactly what it sounds like. You're actually burrowing into the side of the skull, creating holes in order to relieve that pressure. But most likely where the test will go will be with craniotomy. So now let's talk about ischemic stroke treatment. The first thing we should talk about is thrombolytics, such as tissue plasminogen activator, or TPA, or even newer tenecteplase, TNK. TPA is a clot-busting medication used in acute ischemic stroke. It actually works by converting plasminogen to plasmin, which helps break down fibrin, the main structural protein in blood clots. It very much acts like your natural fibrinolytic system. So the goal is to dissolve the thrombus, restore blood flow, and limit the amount of brain damage. Simply put, thrombolytics must be given within the first 4.5 hours of the last known normal. Two things are important here. Exams like to trick you by saying 3 to 4.5 hours for the purposes of your level of education and what the exams are going to be going. All you need to know is less than 4.5 hours, people are able to get thrombolytics. And it's also compared to the last known normal. Last known normal is also important. If someone goes to bed at 11 and they wake up at 5 a.m. and they have signs and symptoms of a stroke, their last known normal was at 11. That's 6 hours ago. That means they are outside of the window for thrombolytics. That's why it is always important to know that when you're talking to a patient in the emergency room when they present with a stroke. Now, when exactly do you give TPA or thrombolytics? You always give this whenever the benefits outweigh the risks. If you have a person who, for example, sings for a living and they present to the ED for aphasia, so they can't speak, and they started about an hour ago, and imaging now shows a tiny M3 occlusion where Broca's areas or the speech center is, this person should still get TPA if they have no contraindications. The reason being is because it doesn't matter how big or how small the stroke is. We give it if it benefits the patient in any way. For example, that one is a singer. The example I gave was an individual who's a singer. Thus, they have a lot of benefit. They make a living off of their voice. Thus, if they can't use it, then that drastically affects their life and their outcomes in life. Thus, anyone who can benefit from it should get it. It is also important to note that if a patient receives thrombolytics, they should not receive antiplatelets or anticoagulation, such as aspirin, clopidogrel, apixaban, until after 24 hours. Now, there are a large multitude of thrombolytic contraindications. There's greater than 20 of them, but some of them you must know. So let's start with the most obvious one. Do not give thrombolytics if someone has evidence of intracranial hemorrhage. If the CT head contrast shows bleed, there's no reason to give thrombolytics because that can worsen the bleeding. We don't give if there's platelets less than 100,000, INR greater than 1.7, elevated PT or PTT. We don't give in individuals with recent spinal surgery or intracranial surgery, or if they have active peripheral bleeding, or if they've had a recent GI bleed within the past month to 3 months, or if they've had a recent stroke. What are all of these saying? If an individual is bleeding, has recently bled, or is at risk of bleeding, do not give thrombolytics. You can memorize all these numbers and all these values and everything like that, but for exam purposes, they're going to make it very obvious. They're going to give you more than one risk factor. The only time that they may not do this is actually for blood pressure goals. We don't give thrombolytics if the blood pressure is greater than 185 over 110. Now, if this is the case in real practice, you can actually give medications such as beta blockers, labetalol, nifedipine, etc., in order to lower that measurement, and then you can actually give the thrombolytics. But definitely know this BP cutoff. Everything else is pretty much just saying do not give thrombolytics if you are at risk for bleeding. Now, further workup and management with ischemic stroke will be mechanical thrombectomy. Now, this goes into a lot more detail than just what's provided, but I think that this is really all you need to know for exam purposes. This is typically done for large vessel occlusions affecting the anterior circulation, such as the internal carotids, the M1 and the M2 branch of the MCA. So the middle cerebral artery has 3 branches, M1, M2, and M3. Typically the larger ones, you can undergo mechanical thrombectomy. The goal window is between 6 to 24 hours, and this typically requires a stroke scale greater than 6. The reason being is because mechanical thrombectomy is invasive, so we want to make sure that they're going to get some benefit out of it. If they have a very mild stroke and they only have a stroke scale of 1 or 2, there's no real reason to put them at such a risk. It is also important to know, just for clinical practice, that you typically actually can benefit more, studies show, from mechanical thrombectomy and receiving thrombolytics at the same time or during the same visit. So that is not a contraindication to getting a TPA. Now, for non-TPA strokes, remember, if it's greater than 4 hours since onset or contraindications to thrombolytics, the patient should receive these 4 things: statins, aspirin, clopidogrel, and BP control. Statins do a lot more than just lower cholesterol. A lot of cardiac studies show that it helps stabilize plaques, decrease inflammation, break down plaques, etc. That's why these individuals are placed on statins. Aspirin, if you do not get TPA, should be given within 24 hours. And some individuals will need Plavix or clopidogrel. They should not make you choose between one or the other. Now, BP control, like we talked about before, is extremely important. And this ties into the next slide, permissive hypertension. So permissive hypertension actually protects the brain tissue during early ischemia by sustaining perfusion until reperfusion therapy or stabilization. The whole idea is your body naturally responds by causing hypertension. We allow that hypertension to occur in order to allow the blood to flow to those ischemic areas. Now, the systolic is definitely more important to know for test day, but I will include some of the diastolics that you should know. For ischemic stroke, individuals who do not get fibrinolytics, do not get TPA, it's typically 220 over 120 is the goal. For ischemic stroke, individuals who have either undergone thrombectomy or have been receiving TPA, it's 180 over 105. And then for ICH, or intracranial hemorrhage, remember that range. That range is still true, but for board purposes, if you had to pick one number, typically it's less than 140. And that is your permissive hypertension numbers. Now, once we diagnose someone and we treat them and we allow for permissive hypertension, thrombectomy, etc., what exactly do we do? The next step is going to be to prevent another stroke from occurring. Why do we do this? Well, remember, individuals who get one stroke are at greatest risk of getting another stroke. Thus, we typically do a workup to see what can we treat to prevent. This consists of an echocardiogram where we look for thrombus or vegetations in the left ventricle, which may lead to further clots, and we treat as needed. Electrocardiogram can also be done to look for arrhythmias such as AFib or A-flutter. It is very important that a lot of people, the electrocardiogram, do not catch any abnormalities because the stroke's already happened. Thus, these people may require long-term monitoring such as a link or cardiac monitor. These people are also placed on telemetry when they're in the hospital. The next thing will be your carotid duplex or your carotid ultrasound. This looks for stenosis. Now, if an individual just gets a normal carotid duplex, if they're asymptomatic and their stenosis is greater than 80%, they can go for a stent or SCEA, a carotid endarterectomy. In the purpose of strokes, if they're symptomatic, aka they just had a stroke, and their stenosis is greater than 70%, then they can go for a carotid endarterectomy, aka, or a stent. Now, there are different classifications. There's a subtype, there's a class 2 classification, which recommends greater than 50% with no other found cause for a stroke. You can go for a CEA or a stent placement as well. But for the purpose of your boards, this is what you need to know. And then, of course, we also look for risk factors associated with this, such as A1C and lipid panel, in order to tell us what medications we can add and to decrease the risk of this reoccurrence in the future. And that concludes this lecture on acute stroke.